Welcome to Healthcare Quality and Risk Matters, the show where we dive into the topics that matter most in healthcare quality and risk management. Wondering about patient safety, quality improvement, or risk mitigation, but weren't sure who to ask or were afraid to ask? Well, you're in the right place. We create a safe and judgment-free space to explore these critical topics together that will leave you informed and inspired to make a positive impact on healthcare and patient outcomes. So let's learn and grow together because healthcare matters.
Well, good afternoon, everybody, and welcome to this June edition of Healthcare Quality and Risk Matters. And I am one of your co-hosts, Gary Bierce, CEO of Aperisoft Healthcare. And I'm joined by my other co-host, Rob Santamore, who is our Chief Operating Officer. And we are excited today because our guest host is someone health systems call when operational clarity and audit readiness can't be left to chance. Please welcome Kelly Malloy. Kelly is a fractional COO and the founder of Malloy and Company, bringing more than 30 years of clinical and operational leadership experience across major health systems. She's known for embedding directly with executive teams, aligning physicians, and turning stalled strategies into measurable performance. Her Propel Forward framework has helped organizations stabilize operations, accelerate integration, and strengthen regulatory and audit readiness during their most critical inflection points. So please join me in welcoming Kelly to us today. We're thrilled to have you, Kelly. Today's topic is all about audit. Rob, you want to kind of give a background about what the month is about and why we're doing it?
Yes, it's Clinical Audit Month. And when we came together as a team, this is such a core part of who we are, right? Audits can be so proactive, they're so helpful. There's all of the small, tiny assessments that you're doing on a regular basis have such a massive impact. There's on your organization. There's jumping on the opportunity to tag on to that Clinical Audit Month. There's to talk about how important there's all of those daily assessments are, all of the there's things that we do every day in the name of quality, risk, and compliance and safety, just the massive impact that it has on the organization, but most importantly, the patients.
It must be an important topic because we got a lot of people who have signed up to attend today. We approached nearly 1,000 people. So thank you, everybody, for signing up for today's podcast. By the way, if you are listening right now, go ahead and get into the chat and let us know that you're here and where you're from. And feel free to give us any kind of comments or questions that you have as we're getting into our conversation. And I'm going to ask the first question. I'm sure everybody out there is going to ask. So, Kelly, what was the worst audit you've ever had to go through? We'd like to hear those details. Tell us what you know.
Sure. So I think the worst audit that I went through was in an organization a couple years ago, and we thought we were ready. And what happened was
it was a scheduled audit.
It was a scheduled Joint Commission triennial survey, and the life safety surveyor showed up with a vengeance. And everywhere we walked, it seemed that he pointed out a door jamb here with chip paint and a door jamb here with chip paint. And, you know, in a hospital with more than 200 beds, there's a lot of door jambs. And it was cited as an infection control risk because chip paint, you can't wipe well, things will rust. And while I understood the intent, it was really overkill. And it actually triggered a critical finding because of the number of citations of chip paint on door jambs. And so we were resurveyed 30 days later with absolutely no findings. But the anxiety that comes from them repeatedly pointing at chip paint just doesn't do an organization any favors.
No. And readiness it just goes to show you can think you're ready, but you're not. Right.
That's right.
And it's the little things that can affect the outcome. Now, Rob, I'm going to ask you to give me your incident from hell, the audit from hell. that you've shared with us before. If you're a regular to our show, I'm sorry, I'm going to have Rob tell the story again, but this is another classic example of why we're talking about audit today. Go ahead, Rob.
I'll keep it. I'll use the abridged version.
Yeah, let's do that.
I vent about it all day. Because ultimately we actually did the right thing. I did many of the interviews myself. And the small pieces of information I was truly able to gather, really did paint a very clear story. Knowing my organization that all of the people did the right thing, but the DOH came in for a for-cause audit.
So this was not scheduled. Something happened and you're showing up. Okay.
And so this is based on a sentinel event that occurred. So those never events that shouldn't happen. Somebody unfortunately was injured and there was an associated complaint. All completely known to us. Unfortunately all of our grievance follow-up with the patient's family. All of the incident. There's management, including the initial mitigation strategy. There's in the patient chart for the patient, and there's the overall process improvement and quality controls put into place were not documented. There's in a system that allowed us to obtain that information cleanly and in a way that told a story. We had to find pieces of information in people's emails, on desktop calendar notes, and Post-its, notepads, OneDrive. There's documents uploaded where people put notes onto a Word document. It was a mess to the point where I created a key of all of the pieces of information, but the integrity of that information was obviously garbage. Post-its don't count. Stuff on somebody's OneDrive doesn't count. And I knew that turning it over, but I wanted to show that we did at least internally communicate as clearly as we did, because it did reach a patient. And we were obviously cited. We were cited for non-performance for responding to a patient complaint and grievance appropriately per state regs. As well as appropriate mitigation strategies for future like events. There's the corrective action. In all associated, financial costs totaled around $4 million by the time our almost 1 year of work and to prove compliance was complete. Mm-hmm. For something that we truly did okay. We actually did it okay.
You did the right things, but you didn't have the right documentation in a readily available place. So that you can tell a clean story with the auditor so they can say, oh, okay, all right. Mm-hmm. Rather it looked like the complaint, right? Everything was suspicious looking.
Of course it is.
And then you lose. You lose every time, right? That's the way it works. So Kelly, going back to your incident, thinking back, what are some tips that you might well give our listeners that you could have done differently, or you wish you would have done differently, that would have made that a completely different experience?
Yeah, absolutely. Well, one of the things, and it's in the newsletter that gets sent out, is that I committed to at least one day a week coming in a different entry point through the hospital. And so that way, you get blind when you walk the same path all the time to the things that exist around you. And you're always on your way to a meeting or on your way to your office, and you've got a million things on your to-do list already from the car. But what I did was commit to entering the building and going a different direction to meetings and from the parking lot one time a week. Because it gave me a fresh lens. So you could walk in and, one of the sticky points a lot of times for surveyors scheduled or impromptu is the loading dock space. There's a lot of hazardous chemicals out there. It's very hard to keep clean and tidy. A lot of things get stacked up. But that is a place that really has a trigger for a lot of surveyors if they walk in that way or they round out that way. But also, even just a different entryway. But if you walk a different way to your office, you walk a different way to your meeting, you are constantly rounding and surveying your areas. And when you go and do meet a family in the waiting room, you know, take a look around, and is there a chair that has a tear that you need to pull out because that's an infection control issue? Is there things too crowded and maybe walkers and wheelchairs can't get through? And I wish that leading up to this, I would have done that practice more, and had more eyes on it, because I love when I have my nursing partner with me as a CNO or as a nursing leader. And so that's why I'm thrilled to be talking with Rob today too, is because if we round at the same time, we have different perspectives. You know, our point of view is different when I'm looking at it from a facilities, life safety, operational gaps. And Rob, as the nurse, is looking at it from a tracing IV lines and doing the hand washing audits. And I'm making sure there's enough hand sanitizer in the hallways. And so if you have the opportunity, this is my second point, if you have the opportunity to round with your partners, then it just enriches what you're catching, and it teaches both of us. You know, here's what I look at from a facility side, here's what Rob as a nurse is looking at from the clinical side. Those were my two big takeaways. The third and final takeaway from that is you have to have a place, and this ties on to Rob's audit from hell, is you have to have a place that is collecting all of your documentation, that's
Right.
collecting these audits that you're doing on a daily basis in your head. There has to be a way to move it from the post-it note into some sort of repository, so that you have that when someone says, well, can you prove it? And then you can.
Yes.
Yeah, and let me interject something there, because when you're talking about systems, it can't just be on a one-lane track, right?
Right.
Right.
There. So, for instance, if you're on a rounding assessment, you should have a tool that can support you, maybe with an iPad, that not only can you be putting in the questions that you're needing to ask yourself as you're doing your rounding, but give you the flexibility to add another. You know what? We didn't think about chip paint and doorway, so now I'm going to need to add that to how I'm doing my rounding, right? And in a way, that's a CAPA being fulfilled. Okay,
that's right.
Great. Yep.
Right, because before a rounding happens, that should have been reported as an incident, right?
Mm-hmm.
Which then generates an evaluation, ultimately a CAPA. You know,
Right.
that kind of dynamic relationship and action going on needs to be in a system. It should not be manual and clipboards and files and filing cabinets. You know,
Right.
definitely not post-it notes.
No. And then the other thing that happens too is
check for chip paint.
I know. I took it so personally. I was devastated for days about this. But the other thing is that if there is a way to do it from your phone, I was sharing with Rob that, my facilities directors and anybody else around me knows that, like, I have to clear out my camera roll every weekend because there are pictures of things that I see as I'm walking by, so that I can remember what it is. But pictures tell a good story. You can snap a picture of a fire extinguisher quality check and make sure that it was done. You can snap a picture of a wet ceiling tile, and you can do all those. Their famous question to me is, thank you, where is that? Out of however many ceiling tiles exist in a hospital or fire extinguishers. But and we all, either good or bad, are tied to our phones. And so it's easy to snap a picture, make a voice note, put something in your notes section, but there's got to be a way that those get cleared out and put in a central location, so that, and if there's a checklist, great. But there's got to be a way electronically to capture everything you need. And then to your point, Gary, is there's got to be a way that if someone says, oh, chip paint on this door jamb, and it's going to a central location, that those of us that check on those go, wow, 6 people said something about chip paint today, or chip door, laminate or counter laminates. And there's that. The second thing I'll say is, hospitals and organizations that do this exceptionally well, that can truly say they have a culture of quality in their organization, don't just leave it to the quality department to solve. And
Right.
so
Yes.
that inevitably has to be where things start, because if an organization assumes that your VP of quality and your clinical nurses and stuff are solely responsible for it, that's where there's some gaps already identified. And secondly, I think that if your quality person does not have a seat at the administration C-suite table, that's also a miss, because what happens is when there is an issue, even a near miss, a good catch, any of those things along the way, but if we don't catch it up front, and then you know who we call first, get quality on the phone, have quality come down, we need to do these things. But the organizations that do it exceptionally well implement that multidisciplinary rounding, or at least a point of view from different perspectives. But quality, they understand that quality is not the gatekeeper and the end all be all to the quality program. It's everybody.
I continually tell you guys, I am not a healthcare guy. I'm not a quality guy. I'm a risk management guy. But you're turning me into one, and I'm certainly a believer. That's for sure. but let me say this. Let me say this. For decades in risk management, we would always say the ownership of a risk is not a central location. Right. It's management. It's line management. It's line staff are really the owners of risk. If they're not risk minded, events are going to continue to happen. Right. And that could be anywhere from the boardroom all the way down to the plant floor. It's the same in a hospital. Quality is not something done by the central office. Quality is something that's embedded everywhere. Rob and I had a chance to meet a gentleman who is the CEO of a small rural hospital out in California. And he inherited a nightmare. I mean, they were like F-rated on Leapfrog. They were struggling. I believe their occupancy rate was down to 50%, and they were only 100 beds. So it was almost to the point of death, right? And teetering on the point of death, this hospital. Well, he came in, he got the whole staff together. He said, from this day forward, right, your job and your number one priority is quality. Quality care for our patients, quality operations with our customer, which may be a patient or their family, right?
Right.
Quality relations with our payers. Everything is about quality around here. Two, and like it, and it's only a small step below, safety. Your safety and the safety of our patients and any visitor in this space. They are the two priorities of this hospital from now on. 3 years later, they're A++ rated on Leapfrog. They have been for 3 years in a row, completely turned this place around. Why? It's a culture of quality, right? And it's not centralized. Every employee owns it. That is the dynamic change right there.
Right. And that culture is the piece that's important, because if your frontline staff taking care of patients, seeing families, being all over the building, don't have their eyes open for the things that are in their world. And it's also helpful, that different perspective. So we encourage, another best practice is we encourage nursing leaders from a med surg floor to go to the orthopedic floor. They can see different things, and vice versa. And when we first rolled that out, someone would say, like, I don't know how to go survey the ICU. Like, I'm not an ICU nurse. But you don't have to be. You don't have to be an ICU nurse to know that when you walked through that door, the magnet didn't work, and that there were signs that, operational people went and pulled down. But we left sticky tape, and we left residue, and we left all of these things there. But nurses know that, and clinical people know that those shouldn't be there, or that if they are, they need to be in plastic things. But you need that fresh set of eyes. We get so blind to it, and when other people walk in and go, oh, this hospital doesn't smell like a hospital, we're like, what does it smell like? Because you walk in it every day, and you need that fresh set of eyes. And so when I say centralized, it needs to be centralized from a documentation, so there's one place to look at.
Process
but not
ownership.
centralized,
Process
being
ownership.
only this small glob of people that are responsible.
Yeah. I mean, it's same with risk management. It's a process ownership. It's a facilitation source. It's a place where thought leadership can start and blossom, right? But then it has to be delegated back down in through that rule of everyone owns it, right? And that is what quality is. It should be operating as. And Rob and I mean, we like to joke about quality and risk, but we have come to the agreement it's one and the same. Quality and risk management are one and the same. That same CEO, you know what he said, Kelly? He said, my word for anybody is that good quality equals good business.
Right.
Now, what he learned through that whole experience was if you're running a healthcare organization, and it doesn't matter what it is, it can be an acute hospital, an assisted living facility, it could be a skilled nursing facility, it could be an ambulatory facility. It could be name all of them, Rob. But it doesn't matter, right?
Yeah.
If you're in the healthcare business, healthcare quality is your business.
And it's your business.
If
you're exactly right. And I'll tell you that the first time, when and I see it happen in trauma centers to rural hospitals, is that if there is a bad outcome, if the culture is not of quality and not of taking care of potential risk opportunities, then what happens is one bad outcome, whether it was they didn't keep me informed, doesn't have to be a sentinel event, but it can be, much smaller than that. Or, when my mom was at the hospital, she had a fall. It can be any of those things. I guarantee you that those comments are the ones that are shared in your community faster than everything was amazing. And so if hospitals say, I also believe that you have to speak the care that you're doing out loud. And so you say, I'm washing my hands so that I protect you better. I'm washing my hands, I'm opening this fresh so that you don't get an infection. Down to housekeepers, we're mopping this, we're doing our 5-step process and changing rags so that nothing gets transmitted in it, so that you go home faster. You've got to care out loud about those things. And then it reminds them, oh my gosh, like everybody that came in here spoke about safety, spoke about quality, spoke about infection prevention, spoke about all those things that then when they get their survey, think they were really concerned. And when, and it's not a one-off, because everybody, when there's a culture of it, is saying the same message.
I am geeking out right now. This is amazing. So I'm not one to sit back and listen during the podcast, because I always feel like I just have so much I want to say, but this has been...
He's glowing over there, Kelly.
This is just fantastic. One, I want to work at your hospital, Kelly. Two, there's, I may go back to bedside at your hospital. But two, I'm hearing both of you talk about there's these single steps, or even like, 2 steps or 3 steps. There's things that are considered somewhat small, but all together, it makes such a massive difference. Kelly, you parking in a different space and like walking through and doing that audit and bringing a partner for multidisciplinary assessment. There's on a continuum. They're speaking about the need for a culture of quality. Gary, you talking about there's adding in payers. Kelly, you mentioning the fact that speaking your care out loud gets you better HCAP scores, which then goes back into Gary's point with the better payer outcomes for your HCAP scores and more retained revenue from CMS. Like the spider web that you both are painting in this conversation of all of those intersecting points, those single points where you're making thoughtful, careful decisions. And that one decision, that one small assessment, that one small idea, there's bringing something intelligent into the organization to make yourself better. So
I once worked for a CFO, and I think I told you this story. And he said, Gary, I want you to understand finance. I'm like, okay. He goes, if you can remember one thing, you'll always have a different perspective that will give you insight. I'm like, wow, I'm thinking I'm getting a bombshell landed on me, right? And the bombshell was, everything in business is a beanbag chair. Your job is to figure out how the beanbag chair works. I'm like, huh? And what he meant by that was when you push in on a beanbag chair, what happens? Pops out somewhere, right? Understanding how that happens is how you know your business. And one of the biggest problems in healthcare is the pushing in on poor quality, and where it pops out is not thoroughly understood by leadership. They don't understand that. And if they understood, that is probably their greatest lever towards success. It would change everything. It would really change everything.
It would.
You have a question?
We do. The question is, how much of a C-level and board-level demand are you seeing for quantification of risk and actions to those most accountable in organizations? There's to those most accountable, there's a high demand. There's to, unfortunately, those that are maybe not doing so well, poor quality scores, high paybacks to CMS, low pay for performance with your vendors or with your payers. There's an unfortunately low volume for especially your electives and all those other things and poor patient outcomes. They're not asking for quantification unless it is a single event and be like, hey, DOH showed up. What's going on with that one?
Now, ParitySoft Healthcare is one of the rare systems that can help you do that. We have Monte Carlo simulation built in, but we're not hearing a lot of healthcare organizations asking for it. And that's a sad thing, because to understand risk in dollars and cents so that boards can understand it, I think is a critical component missing in the whole quality and risk game, for sure.
Yeah.
Now, we have something for the audience, guys, because we have touched on all of it, but we've put together a nice graphic for everybody. And by the way, if anybody wants this graphic, there's a QR code up on the screen right now. Just scan that right now and send us a little note asking for a copy of this. We'd be glad to share it. It's very simple. We were talking, this whole topic today is about being ready for audit, right? But really, if you noticed our conversation, we were talking about preparing and doing a pre-audit assessment. Remember in Kelly's discussion, she says we were ready, right? So she did her pre-audit assessment. However, in her rounding assessments, they weren't checking off yet chip pain, okay?
Right.
And now she was documenting well, but in Rob's example, there was no documentation happening, right? And certainly all of this feeds in through how you manage your incidents. Kelly was talking about that. Look, when this first happened, or when you first see it, when you're coming through the loading dock, write up an incident, right? And then if that ends up becoming a problem or something needs to be addressed, it gets added to the rounding assessments as part of the CAPA. So you see there's like a 4-dimensional dynamic that is all about quality and risk that makes you ready for an audit. So I don't need to get into all the gory details of this graphic, but this is a great thing to pin up onto your cubicle wall or in your office as a little guide of, are you struggling to be ready for audit? Well, this is how you can get yourself ready right here.
And for those that are listening only, there's this 4-loop Venn diagram discusses pre-audit assessment and management. There's which is readiness assessment. There's which reduces surprises, rounding assessments, which allows you to see risk early and act quickly. This is a wonderful opportunity for those near misses and good catches. Those are your more proactive side of risk management, of quality management. Documentation and document control, the right information at the right time. Again, we would have saved my hospital $4 million if I would have had this, right? If I would have had good documentation and just could have accessed it with a click of a button. It would have unfortunately cut into my lunchtime, and that would have been the worst part of that audit. And right, which would be an amazing outcome. And then incident management, where you can, like Gary was speaking to, learning from the events, right? There's, Kelly doing that multidisciplinary assessment, and finding it in the med-surg unit. Now, okay, well, this is maybe something a little bigger, and they're going to cite us for infection control. Let's add it to the environmental of care rounding for all of our units.
Right.
And now that incident allows us to be proactive in all of the other spaces. And that is where your complete audit readiness overlap in that center of that 4-loop Venn diagram. comes in to play.
And I think, Rob, one of the pieces that we haven't talked about yet when we talk about culture of safety and risk is that the environment needs to be safe for people to report what they're seeing, and so another best practice that I have seen organizations do is daily safety huddles. Sometimes it happens in the morning, sometimes it happens in the afternoon, or both. But it needs to be a space where people can say, hey, I have this concern. This is what I saw when I rounded yesterday afternoon. And then, someone else goes, oh, I saw that on my unit too. And there can't be this penalizing, punitive piece for bringing concerns up. It's the only way we know. And I see a question popping up here is the early signs is if you're not bringing up things at the beginning, then you have to trace backwards, and it becomes much more complex and much more layer driven, in operationally speaking, to fix those things. So if there is the culture that exists for capturing, there needs to also be the culture that makes it okay to say there's a gap here.
Agreed. I love that. And Mohammed's question is fantastic. In my experience, and I like that the next question you added was the qualifier for my experience, because the data off the top of my head of what's the most common, I'm not sure. But mine is really, to Kelly's point, it is that loop closure, and the control put into place. There's what actually closed the loop. There's what was the feedback mechanism. Yes, we received the patient grievance. We sent a letter, but what was the outcome? There was an incident with a patient fall. Yes, we did an assessment, but what was the outcome? What additional quality components did we put into place to make sure that it didn't happen again? So loop closure, to me, is the largest piece that is missing. And when you're doing things on a form or paper, you're not going to be able to close the loop because it's a linear function. It doesn't tie back to anything. Mm-hmm. And then we have a specific question asking for Kelly's thoughts on that.
Kelly, please share your thoughts specific to Mohammed's questions. Okay, so my thoughts, Mohammed, about the most common small gap or process that I see ties into Rob's of loop closure and the piece that I spoke about, making it okay to say, I saw this problem. And so I think about in safety huddles where people say, here's a good one. We're short 5 nurses and a PCT today, or a CNA, depending on where you are, geography, they call them different things, but we're short on that. Well, is that necessarily a safety concern? Maybe, but you have to be able to speak to, and I have this many people that are a one-to-one, I have this many patients who require total assist. I have this many people on vents. And then you're like, okay, do we need to shift staffing to help support the acuity of those patients? And what are we doing about it? That's the other piece in that loop closure too that Rob talked about is, not just that you're short. I have a list of 5 other nurses that I'm going to call as soon as this huddle is done. I'm going to see if I'll take, patient load so that we have this, or I will be the rapid response team today instead. But there are things that need to happen so that what seems small in a huddle and brought up isn't. You've got so many people on catheters and you've got so many lines that need to be discontinued. Those things all feed into the amount of care and the amount of work that our frontline staff are going to have to do. And those, I think, are the little things that people miss when they're brought up in meetings, and it just sort of gets said and then people move past it. But if we're not paying attention to really what that means from a quality of care perspective, then there are misses.
And from a systems perspective, Mohammed, if you don't have automation around these different things, you still need to document them. So if you're on the clipboards, that's fine. So have a good filing system by date, so you can find things quickly. In a ParitySoft, Everything is documented for you. All rounding assessments are recorded as they're being done, and as well as with incidents. And incidents are fully integrated through a triage process of what is going on with the incident, through an analysis part of that of the system, all the way through to connected directly and natively back to your corrective action. So now you can, if an auditor shows up and it's on a reaction to an incident like Rob's was, you go to one place, right? And everything is right there. You don't have to go finding things. So as far as I know, we're the only system that truly does that on a native level. But there might be some others that can get close. So, but that's what you really need to be able to close these loops and manage this stuff tightly, so that you're avoiding the fines and the recertifications that Kelly talked about, what have you. So that's our feedback there. Guys, we burned right through our half hour like it was.
Yeah, we did.
We're 6 minutes over. Mohammed, thank you so much for your comment. And for the person who asked about the sea level, thank you about the quantification question. For everyone who has attended, thank you for being here today. It's your participation that makes this worthwhile to us. We're certainly trying to make a difference out there in our community, and we need you to do that. So please like this LinkedIn show. Please go out and on YouTube, check out our old episodes. Just go to the Healthcare Quality and Risk Matters channel, correct, Rob, on YouTube, yes. And you can find all of our old stuff. And we thank you, Kelly, for being our special guest today. You were fantastic. It was a wonderful show, and we're looking forward to next time. So can we talk about July real quickly, Rob? What is the July topic? Do we know?
So next month, we're still deciding, because we're very excited about several different topic ideas.
Okay, so we haven't arrived at what it's going to be yet.
Yeah, and so we're, again, there's so much to talk about. We're going to try to narrow it down a bit more. Okay. But yeah, we are excited.
Well, follow us on LinkedIn, and you'll find out real soon. We'll be narrowing that down for everybody. And we look forward to next month. Thank you for being here, and we'll see you then. Bye now.